Yeah. Okay, so yesterday I got 2. Can you tell me why I got 2? Can you tell me where I got 2? There you go.
Please refer to the complications.
So, which complication did I touch on?
You spoke about the acute respiratory failure. That was the only, yeah, that's the acute respiratory failure.
So we talked about sleep apnea,
Yes, we did.
acute respiratory failure. There's also, let me see whether I can get a board. So you can see the board now.
Yes, sir.
Okay, so the next will be pulmonary hypertension. Pulmonary hypertension. Pulmonary hypertension. The next is pulmonary hypertension. So pulmonary hypertension. Patient can develop pulmonary hypertension through these mechanisms. So we have this to be the heart. We have this to be the lungs. So when we're learning about heart failure, we say that there's a vessel that connects the right side to the lungs. Which vessel is that? Pardon me. Come again. Hey, who is doing that?
Who is morning?
Oh, God. Let me see planning on the move. Who is doing that? I was asking about the vessel that connects the right side to the lungs. And you are yawning. Which vessel is that?
The pulmonary artery.
So these would supply blood to the lungs. And I want to make it so simple for you to appreciate. This side is connecting, so it's taking this blood here, and there will be exchange. And because COPD is affected, when you talk about COPD, the lungs are affected. Because the lungs are affected, if you are talking about emphysema, there's destruction to even the vessels around. There's any supporting organ could be affected because of these mediators, inflammatory mediators, that could damage this. And therefore, blood flow to here will also be affected because the lungs, it will not be easy for the lung to just accept this because of the distraction. So there will be, I'm making it simple, there will be a stream because this blood getting into this will not find it easy because the alveoli is affected. So when the alveoli in this, they are affected, and therefore blood getting into this side will not have that smooth flow. Within the vessels will not have that smooth flow. So there will be a strain here. Why? Because some of these there will be a backflow of some of these blood. That would put a pressure here within these vessels. So there will be a pressure build up within the pulmonary artery. This pressure will put a strain on this side because now if blood flow to this side, it's not flowing freely via the lungs. And therefore, some of these will go ahead and come back. And that will set up a pressure within the pulmonary artery. And this pressure set up within the pulmonary artery will put pressure on this side. There will be a pressure on this side. And this pressure on this side will cause the right side to have this remodeling. So there could be a remodeling activity occurring here because of the pressure, the pulmonary hypertension building up within this, and it will put a strain on this side. And this can cause remodeling to this side. This is one thing that could happen. So a situation whereby we have this, we have problem here, problem at the lungs. That could be as a result of asthma, could be as a result of COPD, could be as a result of fibrosis. If you have a disease condition here, and this disease condition is putting pressure on the right-sided, such that right-sided would undergo changes, and that would eventually lead to failure of the right-sided. When we have such a situation, and we call it pulmonary, pulmonary. So you have right-sided failure as a result of respiratory infection. When you have such a situation, right-sided failure, there's a failure here as a result of respiratory infection. When you have such a situation, we call it pulmonary or pulmonary. So this is one of the complications that could come as a result of pulmonary hypertension due to the COPD causing destruction to the lungs. This will put a strain. There will be pressure buildup within the pulmonary artery. And this pressure buildup will put a strain on this side, the right side. So when you have right-sided failure as a result of respiratory infection, when you have such a situation, we call it pulmonary. Call it pulmonary. Another thing that could also happen is that, which is dangerous, is that we have low oxygen. There's low oxygen as a result of the COPD. There's low oxygen. And this low oxygen, let me ask you this, who can tell me the danger of having low oxygen in your system? Who can tell me one of the dangers of having low oxygen? Am I muted? Am I muted?
The question can okay.
Low oxygen. One danger of low oxygen.
Lead to respiratory collapse.
You're talking about, you don't talk about hypoxia, you're talking about ischemia, you're talking about respiratory collapse, you're talking about what? One danger of low oxygen is that it will lead to more production of red blood cells. Low oxygen will lead to more production of red blood cells. And this, when you have more production of red blood cells, it could lead to what you call polycythemia. So you could have polycythemia as a result of having low oxygen. But this will be a compensatory mechanism where the system will produce more of the red blood cells. If the system is producing more of the red blood cells as a result of low oxygen, then the system could have this. The danger of having polycythemia is that polycythemia would increase blood viscosity. Polycythemia will lead to increase in blood viscosity. And when you have blood viscosity being increased, then the danger will be that there could be coagulation. So low oxygen will lead to increase in red blood cells, which could tip the patient to polycythemia. Polycythemia could also would increase the viscosity of the blood. And when you increase the viscosity of the blood, the danger is that then the system will become hypercoagulable. The system will become hypercoagulable. It means there could be a clot at any time when the system is viscous. And then there could be thrombosis. Please, is it clear?
Yes, please, today.
Mm-hmm. Is it clear to everybody?
Yes, please. Yes, please.
Okay. So we're talking about COPD. We say that COPD is basically we have the emphysema, we have the bronchitis. Basically, we have the emphysema. Please, can you hold on a bit for me?
Yes, please.
Somebody came to my office. Just hold on for me. So we said that, sorry, somebody popping into my office. I have to pick something for them. Okay. This is okay. So I said that for emphysema, COPD basically is made up of emphysema and bronchitis. So when you talk about emphysema, there are types of emphysema. There are types of emphysema. So let's talk about the types of emphysema. Types. So basically, we have other types, but two main types of emphysema. Two main types of emphysema. So we have central lobular. We have central lobular. Lobular, or can also be called central acina. Centrilobular or centriacina. This is one type of emphysema. And these type of emphysema occurs. It occurs at the respiratory bronchioles. It occurs at the respiratory bronchioles, where there's a loss of respiratory bronchioles. There's a loss, destruction of respiratory bronchioles. And this does not affect, because it affects the respiratory bronchioles. It's not affecting the alveoli, the alveoli duct. That is the proximal portion of the acids. The proximal portion. This is affecting the proxima, the beginning. We have the entry. When you talk about respiratory, I drew the respiratory bronchioles. We have terminal bronchioles. the bronchus that comes before. And respiratory bronchus enters the lung and is connected to the alveoli. So when you have the lungs like this, we have the bronchus. So what enters here before it gets to the alveoli? We have alveoli duct, and the alveoli duct connects the respiratory bronchus to the alveoli. And this becomes the terminal bronchus. Respiratory bronchus gets in there and attaches itself to alveoli via the alveoli duct. So when you are talking about central lobular or central acina as a type of emphysema, it's a type of emphysema that affects the respiratory bronchus. It affects the respiratory. There's a distraction to this respiratory bronchus. When we have this will cause emphysema. That type of emphysema is called central lobular. The second type of emphysema is called panacina. So we have panacina. That is the second type, panacina emphysema, second type of emphysema. And these type of emphysema affect the lung fields, affect the whole of the lungs. So it affects the lungs. This is not only affecting the respiratory. Panacina affects the whole of the lungs. When you have this, the whole of the lungs being affected as a result of these inflammatory mediators, then we term that type of emphysema as panacina emphysema. So basically, this is the two types that we have. Find out this for me. I'm giving you assignment. Find out this assignment for me. When we could have find out the difference between compensatory emphysema, compensatory emphysema, emphysema, and emphysema. Find out the difference between this compensatory emphysema and emphysema, and find out between emphysema and empyema. Find out emphysema and empyema. What is the difference between empyema and emphysema? And the difference between compensatory, the difference between compensatory and compensatory emphysema and emphysema, and emphysema and empyema. Final. So let's move quickly to the investigation. Move quickly to the investigation. So for investigation, so the first thing that should be done, is the lung function test. Lung function test. We have kidney function test. We have the lung function test. And these can assist us in the diagnosis to have this. And we have a small instrument, spirometer. We have a small instrument, spirometer, that are used for this lung function. And this spirometer will measure the lung volume and the flow rate. To measure the lung volume and the flow rate. This is spirometer. So this will measure. These are some of the parameters that this spirometer will measure. So we have the main parameter that could be measured, but we have other parameters. But the main one is the FEV1. FEV1. Yeah. Hi. Hello.
Hello.
Sorry, some of the lectures came in. So, okay, so the main function, the main parameter that I measure, that is the main, but we have other parameters. The main measurement is the FEV1. And what is FEV1? What is this? What is
It is
FEV1?
the first expiratory volume in 1 second.
Come again.
The first expiratory volume in 1 second.
The first force expiratory volume in the first second. So what is that? Who can explain this to me? So who can explain this to me? Force expiratory volume. Force expiratory volume. Who can explain this? Because this is the main thing that are being checked. But we'll also be checking vital capacity. We'll also be checking force vital capacity. We'll also be checking. So who can explain this? Force expiratory volume.
Hello.
Hello.
Yeah, so please, the first expiratory volume is the maximum amount of air the patient can expel during the first second after maximum inhalation.
So that you are right. The parameter, the spirometer would measure the F. What you said, you are right. It will measure that. And this parameter is very, very important. I'm saying it's the main parameter. Okay, other parameters that could be measured is also we have vital capacity. Vital capacity. So the spirometer can also measure the vital capacity. The vital capacity. The vital capacity is also the volume of air inhale and exhale during maximal ventilation. It will measure the volume of air inhaled and the volume of air exhaled during the maximal ventilation. So when you have maximal ventilation, you can measure the volume of air. So if the volume of air, it's measure the volume of air, the amount is small, the volume is small. The amount of air exhaled, which is also small, then it means that the capacity of the lung is a problem about the lung capacity. So there will also be force vital capacity. Another parameter that could also be checked is the force vital capacity.
Dr. Attakorah.
Hello.
Attakorah, please, I just want a clarification. Please, when we started, you said the investigations, we do the lung function test. Then we started mentioning these parameters. So I just want to know if this FEV1 and vital capacity are under the lung function.
Shouldn't have asked me this. Shouldn't at all. I always ask me this. Who is asking?
Benedicta.
Ben, I want to see your face. Ben, let him see your face. Why?
Okay. I will show you. I'm coming.
Yeah. Ben, you shouldn't have asked me this at all. We are talking about the lung function. The lung function. Basically, tell me what the lung does. Basically. Hey. Hey, tell me what the lung does. Basically. Benedict, tell me what the lung does. Basically.
Dr. Attakorah, it helps us take in oxygen and bring out carbon dioxide.
So, exchange of what? Gases.
Yes, sir.
Exchange of gases. So if you want to find out that your lung, there's no problem about the lungs, what are you going to do? You have to measure. You could measure the amount of air when you have inhaled, and measure the amount and see that the amount that is within the lungs are okay. And you can measure when you have exhaled, amount of air that comes out. When you measure the normal amount, then a patient is having reduced amount of this. You can say that your lung has a problem. So the lung function test, these parameters. So I said that we use spirometer to measure the lung function test. And these are some of the parameters that could be measured using the spirometer to measure the lung function test. And these are some of parameters that could be measured to see that your lung is functioning well. When we're talking about liver function test, there are some parameters that we mentioned. So when you are measuring lung capacity, vital capacity, then you should know that you want to know how your lung is functioning. So the vital capacity, we said that the vital capacity will be measuring the volume of air inhaled. So if assuming you have COPD or assuming you have bronchitis, it will affect the amount of air that will get into the lungs. So the spirometer will measure the amount of air that you inhaled. Spirometer could measure the amount of air that you exhale. And if there's reduction in this amount, then there's a problem. So please, the lung function test, these are the parameters that you'll be checking under the lung function test.
Yes, sir. Thank you.
The parameters, the same as the liver function test. Tell me some of the parameters that were measured under liver function test. Benedicta.
So,
Tell me.
we mentioned the AST, the ALT, and the GGT.
It's the same as the lung function test. We're checking the FEV1, VC, and CO. You get it?
Yes, please.
It's all parameters that should be checked under the lung. So VC, vital capacity, the volume of air inhaled and exhaled during maximal ventilation. So when the ventilation is good and you measure the amount of air that the patient inhaled, once we have a maximal ventilation, and if you are not getting the correct amount, then it means that there's a problem about the lung. There could also be faults. There could also be faults. These are all parameters that cause vital capacity. These are all parameters that are measured just to find out how the lung is functioning. So forced vital capacity is also want to measure the volume of air inhaled and exhaled during a forced maximal expiration after full inspiration. It's almost like the vital capacity, but the difference is this. The volume of air inhaled and exhaled. So you inhale a volume of air and you exhale a certain volume of air during a forced maximum expiration after full inspiration. So that is the forced vital capacity. The last parameter that could be checked is the residual volume. So residual volume is amount of air that is left in the lungs after you exhale. The amount of air that is left within the lungs is the same as the residual volume. We talked about the residual volume when we're talking about the heart failure. When we're talking about the stroke volume, we talked about stroke volume. We talked about residual volume. Also here we have the residual volume, which is amount of air left after maximum exhalation. After you have exhaled, the amount of air left in there. So these are some that could be measured. But I said that the main parameter is let me clean this. Okay, it's the FEV1. And these parameters, when you want to check whether there's airflow limitation, you want to check this parameter whether there's airflow limitation. So to use this parameter to check whether there's airflow limitation, then the FEV1 should be less than 80%. Should be less than 80% of that, then we'll be suspecting of airflow limitation. If a patient is at the ward and you check the oxygen, what do you use to check oxygen at our hospitals? Which instrument do you use to check?
The pulse oximeter.
The pulse oximeter. It will check the oxygen. When you check the oxygen, and it means that you need to, because you need to be getting the 8. If you are getting the 96, then there's a bit of question mark. Getting 98% or so. So the moment the spirometer check the FEV and it's less than 80% predicted, then you should suspect airflow limitation or airflow obstruction. There's airflow limitation or airflow obstruction. And there could be also a ratio. There could be also a ratio of FEV1 over FVC. And this ratio, when it's less than 0.7, when the ratio of this is less than 7, then we should also suspecting of what airflow limitation or airflow obstruction. So either use the FEV1. FEV1 should be less than 80%. When it's less than 80% predicted, then it means that there's airflow obstruction or airflow limitation. When the ratio is also giving you less than 0.7, then there's also airflow limitation. So if a patient, let me ask you this, if a patient comes with bronchitis or emphysema, what will be the vital capacity? What will be the vital capacity? Will it be increase, or decrease? The vital capacity, which is the volume of air inhaled and exhaled during the maximum ventilation. So we have the maximum ventilation. So one will also be. So what will be the vital capacity when a patient comes with bronchitis or emphysema? Am I muted? Am I muted?
No, you aren't.
Simple question. I'm asking you this. What will be the vital capacity of the lung if a patient comes with bronchitis, emphysema?
Doc, please, I believe it will be reduced. The vital capacity will be lower.
Believe.
Yes, sir.
I'm saying you believe.
Please, I know.
Hmm? So don't guess, right? Don't tell me I believe. What will be? Will it be increase or decrease the vital capacity? And explain why it will reduce or it will increase or it. Hmm?
Oh, please, it will be reduced.
Explain why it will be reduced.
Okay, so please, in the bronchitis as well as the emphysema, we've come to know that there will be distraction of the airway. So although the patient will be able to inhale some amount of the air, due to the distractions of the airway structures, he or she will not be able to exhale maximal air from his or her lungs due to the damaged structures.
So the vital capacity will be what? So will be reduced or will be decreased. The vital capacity will be decreased. What will be the residual volume?
That place it will be higher.
So the residual volume would increase. But comparing emphysema and bronchitis, which one will have a higher? Some of you are confused. What I'm saying. Which one of you will have a higher residual volume? Good. So the emphysema will have higher. The emphysema will have higher residual volume because air is trapped because of poor exchange of air. Air is trapped in the alveoli. So the residual volume will be high as compared to the bronchitis. So what will be total? I'm just asking the total lung capacity. Total lung capacity. Emphysema and bronchitis. Emphysema and bronchitis. How do you compare their total lung capacity? Total lung capacity. So total lung capacity, let me say it first to move faster. Total lung capacity is often normal. It's often normal in bronchitis. The lung capacity, that it would increase in emphysema. The lung capacity will increase in emphysema. So these are some of the parameters that are used in terms of what? In terms of diagnosis. in terms of diagnosis. This let's talk about the management. So management. How let me ask you this, how will you initiate? How do you think about COPD in terms of the management? COPD in terms of the management. What will come into your mind as pharmacists?
So please, what will come in my mind is that because it's an obstructive pulmonary disease, there should be management employed to enhance or reduce the obstruction caused by the condition. So pharmacological agents that will reduce the obstruction or enhance airflow within the lungs.
Okay. So you think about there's airflow limitation. So what should we do? There's airflow limitation. What should we do? So now you have mentioned about pharmacological. First, A. What will be your A? What will be your A? Then we come to non-pharmacological. And
So please, one of my aims will be to reduce the exacerbations because it's a progressive disease. I can't stop the progression, but the number of times the patient will get exacerbations, I can reduce it.
So you cannot stop what? The progression. Why can't you stop the progression? So why can't you stop the progression? If you know what is causing it, if you know what is causing it, can't you stop that? Assuming it's the cigar, it's the tobacco smoking, it's the cigarette smoking causing that. Can't you stop the progression by stopping the tobacco smoking? So you are right. So you have to prevent and treat the exacerbation. Think about prevention and treat exacerbation. What again? You have to think about relieving the symptom. And you have to think about preventing progression, preventing disease progression. Preventing disease progression. At times, questions will come. So the aim of the treatment, try to be the goal, the aim of treatment. So to prevent disease progression, you should be able to do that. When you know the causative agent, what is causing it, then you have to tackle it. By so doing, you prevent disease progression. Think about relieving the symptom. Think also improve. Think also improve. They cannot tolerate exercise. Small thing, then they'll be panting. So we have to improve exercise tolerance. And in all, you have to improve the health status of the patient. You have to improve the health status of the patient. In all, you have to improve the health status of the patient. And by so doing, you'll be able to reduce mortality. By so doing, you're able to reduce mortality. Okay, so non-pharmacologically, how will you go about non-pharmacological?
Doc, please, we look at the noxious particles that is causing the damage to the airways. So if it is smoking, the patient will quit smoking. If he or she is in activities that expose him or her to chemicals that cause damage to the airways, then we can prevent that too from happening.
Okay, so smoking, tobacco. So the patient has been smoking for years. You know that there's addiction in smoking. Cigarette smoking, there's addiction. Patient has been smoking for years. So we need to think about smoking, tobacco or cigarette smoking cessation. We need to think about it. How do you go about this smoking cessation? How do you go about it? Smoking cessation? How do you go about it?
Provide nicotine replacement therapy.
So you provide what? You provide what?
Nicotine replacement therapy.
Nicotine replacement therapy. Mm-hmm. So this is the general word, big word. Provide nicotine replacement therapy. So how do you go about this? Because smoking is like a drug addiction. The patient is addicted to. So it will require self-motivation. It's like drug addiction. Patient is addicted to. How are you going to provide this nicotine replacement therapy? Can you help me?
So it usually comes in the form of gums. So gums, sprays, or patches filled with nicotine. So for the gum, for instance, you can ask the patient to take one gum and chew it for an hour till the nicotine inside it has been drawn out, just so that the nicotine doesn't have to pass through the respiratory tract.
Okay. So if I ask you to design a strategy to help this group of people, what are some of the strategies? I'm asking you a general something. Now, patient comes. It's addicted to tobacco or cigarette. What are some of the strategies that you would adapt?
One, keep them at a rehab center.
So you keep them. You keep them at rehab center. What next? What next?
Then you provide them with
I'm listening.
you provide them with other forms of nicotine aside the cigarettes or the smoking.
So only one strategy that you have, just to keep them in the rehab.
I think we first do the.
So please, they could be encouraged to join support groups, addiction support groups.
So we encourage them to join these groups. Then you can talk to them in a group, such that these patients could support one another. Any other?
The psychotherapy for them to accept, go through the process of change before they accept that they want to stop. Then before now, pharmacological therapy can be implemented.
So there could be individual behavioral counseling. Individual behavioral counseling. You need to do it. And we need to do group behavioral therapy or counseling. And you try to use the self-help materials. Try to come out with self-help materials. Materials that could help with them individual. You create something for. And there should also be strategy. If they are not in the rehab, they are in their individual houses or they are in a rehab. There could be a telephone call to talk to them intermittently, to keep on counseling. So find a strategy not to just go straight away, to just find a strategy. What strategy can I adapt to help the patient? Okay. So back to now the nicotine. Back to the nicotine therapy. Back to this. Let me ask you, what does the nicotine do? Who can tell me what nicotine does in these patients?
Please, it will give them euphoric effects.
I'm not talking. Am I muted, class?
No, sir. Yeah. Not.
Minute. For nicotine replacement therapy, what will nicotine do? The mechanism of action for nicotine. Yeah.
Yeah, please. So the nicotine works by binding to nicotinic receptors in the body, and when it binds to them,
In
it,
where? In where?
in the brain.
In the brain. Good.
So when it binds to these receptors, it relieves the patients of the craving. So the nicotine help causes them to crave for the cigarette, and in this case we are providing a nicotine not in a smoke form but in another form that will be able to stimulate the same receptors and reduce the craving. So with that, and they wouldn't smoke here. So they will get the same from the.
If you stimulate the nicotine receptors, what there will be release of something. Of this craving. So there will be a release, and this will help in the reduction
The craving. So the nicotine help causes them to crave for the cigarette, and we are.
So note the stimulation of the nicotine in the brain will cause release of dopamine, and this would aid in reducing. So we are talking about nicotine replacements. We have the types. So we have the patches. And for the patches, we have the ones that could cover for 24 hours. And we have ones that could cover for 16 hours. And the strengths that we have 7, we have 14, and we have 28 milligrams. For the 24-hour, have also the strength 5, we have 10, we have 20 milligrams. We apply this once a day. And we apply these patches. Once a patient is going to apply these patches, what would you? What are you going to? How do you prepare the patient for these patches? So the patient is going to apply these patches. What are you going to tell the patient? How do you prepare the patient? Or you just tell the patient to? Do you get my question?
Yes, please. So please, you tell the patient to make sure that the area they apply the patch on is clean and dry, and it shouldn't be applied on broken skin.
So it's important. It's be clean. The area should be clean. And what again? Unbroken skin. Unbroken skin. And what again?
The place shouldn't be hairy.
The place shouldn't be hairy. Good. But these things, we don't tell our patient. These things, because we are not familiar with it. So the patient is going to apply these. So we tell the patient you shouldn't apply it at where there's hairy, non-hairy areas. So on broken skin. And when you have this area this time, today, the next day, don't apply it to the fresh site, all the time. And normally, the sites could be the upper arm, the hip, or could be the trunk. You apply it on the upper arm. So today you apply it on the upper arm. Tomorrow you can do the hip, you can do the trunk, you can come to and come some of the side effects. So basically what we are saying is that if a patient comes with skin disease, don't apply it where the patient is having the skin disease. If a patient is having skin disease, don't use. You shouldn't apply where there's a skin disease. Because of time, when I ask you questions, you don't. What are some of the side effects when you apply these patches?
Hello, Dr. Attakorah.
Hello.
Please, concerning the skin disease, is it that they are not supposed to use it at all, or they shouldn't apply it to the affected area?
To the affected area. Huh?
Thank you.
To the affected area. Okay. So it should. What are some of the side effects of using the patch? So normally as asking side effects, there are certain side effects. When I ask, I'm expecting a quick because it's not thinking. You shouldn't think about these things. I'm asking about side effects. I'm applying patches. What could happen to the skin? Irritation. So these things, you shouldn't think about it. There could be skin irritation or skin rash. So there are certain things that could be asked. Then you shouldn't be thinking about, I'm applying to the skin. What could happen to the skin? Irritation. Or there could be rash. So normally these nicotine replacement therapy, you could have a long-acting ones and you could have a short-acting ones. So normally these transdermal patches will be having that long-acting effect. Transdermal work for 24 hours, work for 16 hours. Will be having this. The short-acting are the gums. The gums. And somebody was trying to explain the gum. So the short-acting, the gums. So it comes in 2 to 4 milligrams. The gums comes in 2 to 4 milligrams. And somebody was trying to tell us how to go about it. Who was trying to do that? So he said you should chew until the taste is strong. So you put it in your gum, you chew. You chew. So you chew for some time and the taste becomes strong. Then you rest. You rest for some time. Then also do it until this taste will be faded or dissipate. So you rest, you tell the patient to chew. When the taste is strong, so the patient will rest for some time. Then you continue until the taste fade or dissipate. That is that. So who can tell me? This is practical. Who can tell me this? What are some of the limitations of using this gum? So what will be some of the limitations of using this gum? What's some of the limitations?
The mouth becomes sore and also the jaws hurt.
The jaws hurt. And there could be sores. So you chew this and there will be salt. Or it can cause. So it's not advisable, it's not good for those with dentures. It's not good for those with dentures. Limitation. It's not good for those with dentures. So for this gum, we say that it comes in 2 to 4 milligrams. And the patient can take about 10 to 15 pieces. The patient can take about 10 to 15 pieces a day. So you can decide to take one piece for an hour. Take one piece for an hour. Then you chew it. As we said, there could also be lozenges. And now, when you are chewing this gum, be careful. Be careful. Why am I saying you should be careful? Why am I saying you should be careful about these gums and lozenges? Who can tell me why am I saying you should be careful? That the patient gets the right thing.
So please, I'm thinking the patients could get addicted to the gum or the lozenges.
You are not in my mind. Saying the patient gets the right thing. Because now they have a lot of formulation. You could get the way that the students are taking. They can make it like gum. They can make it like lozenges. And they are taking it. Can make it like bread. And they'll be taking it. So make sure the patient gets the right thing. The lozenges. So you allow the lozenges to dissolve in the mouth. So 1 lozenges per hour. 1 lozenges per hour. You put it, you allow it to flow, move in the mouth. 1 lozenges per hour. You could also have the sublingual. You place under the tongue. sublingual, the same 2 to 4 milligrams sublingual. Also place it under the tongue. You can also have inhalator, the one that you inhale, inhalator. So it's 10 milligram per cartridge, 10 milligram inhalator. So we also do that. And who can tell me one advantage? One, this one there, the one who get it right, to have a prize. Who can tell me one advantage of using the inhalator? Who can tell me?
Attakorah.
Hello?
Yeah, it has a quick onset.
Who can tell me the lozenges, the sublingual, they all have quick onset? Because these inhalator would be absorbed by the buccal mucosa. So I want you to tell me.
So the inhaler makes the patients feel as though they are smoking cigarettes.
You are getting the, and so in what? Tell me some of the behavior that will make the patient feel that he's taking.
Yeah, please, the hand to mouth movement, the inhaler would mimic that.
So good. So it's good for those who makes the physical act. The physical act is now taking the cigar to the mouth. These movements, back and forth, back and forth.
Doc, please question.
Mm-hmm.
Doc, please, if it is with the hand to mouth, the gum too, they put it in their mouth as well as the lozenges. So please, what makes it different?
This we just put it once. Mm-hmm.
Okay.
You just put it there once. So this inhalator, you are inhaling. So you can inhale for some time. You stop, you inhale. So that movement will be there as compared to. So if a patient makes that movement, that physical movement, using the inhalator will bring it out. There's also the nasal spray. The nasal spray is also there. The nasal spray is also there. But you could also have some medications that could also be used. Some medications. Some of the medications has a primary indication. Some are antidepressants, but they are used to manage a patient who wants to stop smoking. What are those medications? You can mention one medication to me.
Bupropion.
Bupropion. And 2 is what?
Varenicline.
2 is varenicline. 2 is Nicotine. So you please read about these medications. Read about these medications. We use these medications to also help the patient. Opium is an antidepressant medication, but you still use it in that. Nicotine is also used. So let's go back to our COPD. We have learned something about this nicotine replacement therapy. We have learned something. Is that not so?
Yes, sir.
Mm-hmm. So let's go back to the COPD. Now we have tackled the triggers, the tobacco, the cigar smoking, the major trigger of this COPD. We want to prevent progression. We are tackling the source. So now, patient comes with COPD. Patient comes to pharmacological. How are you going to go about it? Pharmacological. Pharmacologically, how are you going to go about it? Hurry up. This is not difficult. Pharmacologically, how do you go about it?
Doc, please, you give a long-acting bronchodilator, the mascaronic.
So I'm expecting you to say you give bronchodilators. Why do you start with long-acting? Why do you say long-acting?
Doc, please, I'm sorry, you can do that.
Come again. You said what? Come again. You said what?
No, please. I thought the one was the former, so that's why I added the long act.
Sapon, you said what? I'm not getting your line. Is always a problem. So you think about the bronchodilators. When you think about bronchodilators, if a patient comes with an acute airway limitation, that's bronchoconstriction. That's airway limitation. The first thing that you think about is to open up the airway. You open up the airway. So you'll be given these short-acting beta-2 agonists. So SABA. You give this SABA, short-acting beta-2 agonists. This SABA. If you want to relieve the symptoms, improve the exercise tolerance, want to relieve the symptoms, such as wheezing. Wheezing. So you want to do that. So we use this. If the patient is not getting relief, so for the short actings, you can also give LABA. So what is LABA for the short acting? . What is LABA? Sorry, the short acting is SABA. Sorry, nothing.
Attakorah, please, your line is going up.
It's going up.
Yeah, I can't. I don't know if it's from my side, but
okay. So sorry, I was saying SABA is so short acting. What is this?
Please, short-acting muscarinic antagonists.
So short acting. So you can also be given this when patient comes up in acute state. And why is it that? Why do we consider this drug and it's more effective? This is more effective in COPD. Muscarinic antagonist. Why do we consider this medication in COPD? Who can tell me why we consider?
Dr. Attakorah, please. The summer helps with bronchodilation and also helps to clear the excess mucus.
I'm asking you, why do we consider this? You should be first tell me what it does before you tell me the aftermath. Why do you consider this? Yes? Why do you consider this? Oh.
Doc, please, the summer will antagonize MP receptor in the lungs and cause bronchodilation.
So do you have it in the lungs? Only. So we have it's effective over the wire because we have muscarinic receptors. The receptors are located along the airways, the bronchi. So you have the lungs. So we have M1, M2, and M3. So these receptors are found. And when you stimulate these receptors, you're going to cause bronchoconstriction. So you block this to cause dilatation. It's effective. Why? Because we have these muscarinic receptors there. You have so much of these receptors there. So when you block it, it's going to aid in the dilatation. So it's used. So when you consider the short acting and the patient is not getting relief of breathlessness, and you can move to the long acting. The long acting. So you can have this. You can have this, the LABA. You can have the LAMA. So when a patient is not having this relief, when you give these short actings, you can move on to the long acting. When you put your patient on this, the patient is still having issues, say the FEV, when the FEV is greater or equal to 50, you check the FEV, 50% predicted. When it's greater or equal to 50%, then you can consider this long acting. When the FEV is less to 50%, then you can consider these long acting plus ICH. So you know ICH. What is ICH?
Inhaled corticosteroid.
So you start with these COPD is involved. Inflammatory activities are involved. Inflammatory activities are involved. So there will be a wheezing. So asthma symptoms could be experienced. So you give this. Normally, patients with COPD will not respond to this normally. Normally, they will not respond. I told you to find out why they normally. I'm not saying they will not respond at all because there's inflammation. They will respond, but normally they will not respond. I was asking you why they will not respond. I told you to look for it. So if the FEV1 is less than 50 or equal to 50%, you can do the LABA plus ICS, or you can combine the LABA. You can combine the LABA. You can combine the LAMA. You can combine these two, the LABA or the LAMA. Or you can do LABA plus the ICS. You can do this. Who can tell me why normally the COPD patient will not respond? I told you to find out this. So other medications can also be used. And other medication we are used in asthma. Example, theophylline can also be used. Theophylline can also be used. Other medications like Nicoletics. Nicoletics can also be used. And we expect the Nicoletics to break down, especially Solomon Mensa, please mute.
Look, I'm very
Dr.
sorry.
Attakorah.
Huh?
Dr. Attakorah.
Yeah.
Please, I just want an explanation here. You said that if the FEV is greater than or equal to 50, we consider short acting. So I was just thinking the FEV, the amount of air that the person is able to exhale. So if it is,
come again.
You said that if the FEV is greater than 50%,
I am saying
greater than or equal to.
No, I am saying that if a patient comes with that hint, and you try to give a short acting, and if you give the short acting, and the patient is still having this breathlessness, then I was then using this. If the FEV is greater than or equal to 50%, then you can use the long acting. Whilst you started with it, the short actings, and the patient is not responding to the short actings, and you check the FEV. When you check and it's greater than this, then you can safely go in and use the long acting. Do you get what I'm saying?
Yes, please.
So we try to start with the short acting. And when you start with the short acting and it's not working, and if the FEV1 is less than 50%, then it means the situation is getting worse. Therefore, you can go in using a combination. You can combine LABA. You can also combine the LAMA. You can also try to add on these steroids. But we are saying patients normally don't respond, but we still consider. So start with the short actings. When they are not getting relief, then you'll be using this. You can, in terms of, I don't know whether you will need it. In terms of these FEV could tell you the severity. FEV could tell you the severity of the COPD. So SEV, when it's greater than 80, when you have SEV greater than 80, so the word that is used is predicted, greater than 80, we say it is stage 1. Stage 1, which is mild. One is between 50 to 80. We said it's stage 2. Stage 2 is moderate. One is between 30 to 49. We say it's stage 3. Stage 3. Stage 3, and it's severe. One is less than 30%, and it's stage 4, and it's very severe, very severe. So when it's less than, so when this is greater or equal to 50, you will say it will be moderate. Moderate. And if it's moderate, Hold on for a minute. Hello.
Hello, Doc.
So these we could use this to tell the severity and the staging of the COP or the airflow limitation. The airflow limitation, you can use this to tell. So when it's greater than 80%, it's the same as if a patient comes with oxygen saturation, or if oxygen saturation is 80, it's not good to be marked. And so we try to give the patient oxygen. So 50 to 80, that is FEV1 greater than 50. When we have this range, then we say it's moderate. When it's moderate, then we think about either giving the long acting, either one LABA or LAMA. When it becomes less than this, then that is stage 3. Less than 50 becomes stage 3, which is severe. When you think about either combining the two, the LAMA and the SABA, combining the two, and you can even add the steroids to it. Use the steroid. You can do LAMA plus the steroids, or you do the LABA plus the steroids. And when it's less than 30, then it's very, very severe. Very, very severe. So this is how we can use the FEV1 to talk about the severity of that. So we employed these, if a patient comes, let me say this, at times these patients will be working with his or their own cylinders. At times they will need long-term oxygen therapy. They'll be working with cylinders because they need constant oxygen. They need that. So you can employ tubulin. It's not like asthma where you think about giving the steroids. You are confident that when you give steroids, you are sure of the outcome. But this one, you are not sure of the outcome. But still, because we have the inflammation portion, you still think about considering that. We can also consider mucolytics, especially in bronchitis. You can consider mucolytics in bronchitis. We can also consider antibiotics, especially in bronchitis. We can consider antibiotics. So you should know the medications. You should know the organisms that will be implicated and the medication that should be considered. So tell me one or two or three microorganisms that are implicated in bronchitis. Hello. Hello.
Hello, sir.
I was asking, antibiotics are considered, especially in COPD. Antibiotics are, especially in bronchitis. Antibiotics are considered. I'm saying, tell me some of the implicating organisms. Some of the implicating organisms. What are some of the implicating organisms? And what are some of the agents that could be used to?
Mycoplasma.
What are some of the agents that could be used to treat those organisms?
Azithromycin.
You consider azithromycin for strep pneumonia. Sana otion.
Doctor, he mentioned mycoplasma.
I mentioned
He mentioned mycoplasma and he said he will use azithromycin for the mycoplasma.
Okay. Okay. So I'm saying strep pneumonia. So for strep pneumonia, which agents are you going to use? But last, when we are talking about the implicating organism, you have strep pneumonia, you have H influenza, and what? Talking about Morozella pathohalis. You could be considering the azithromycin as an adjunctive treatment because there could be normally these respiratory infection. We do add on. We do add on. We could add azithromycin as adjunctive treatment. We could do that. But you should think about giving amoxicillin, giving erythromycin, giving something that could tackle these bronchitis. Okay. Any question?
Attakorah.
Hello.
Yeah, please with the sorry for taking you back with the what do you call it? The nicotine replacement therapy. The skin patch. You made mention that you don't apply it to a broken skin. I wanted to know, is it because if you apply it to a broken skin, the rate of absorption is going to be increased than what it's supposed to be doing? So that's why we don't apply, or there's another reason for not applying on the broken skin?
So I shouldn't have answered you that. If there's a broken skin, what to have? Tell me.
I was thinking if the skin is broken, the absorption of the drug from the patch into the body would increase than the normal. That was the only thing.
It would
that was the only thing.
Okay. Answer this, and it will be the same as this. You have the GI. And if you have ulceration of the GI, when you give the medication, absorption will increase. You have ulceration, ulcers. Will it cause increase in absorption?
No.
So why do you say that when you have a broken skin, you have disrupted that pathway, how the skin, the process of absorbing it, you have disrupted.
Okay.
So why do you expect it to be increased? And the broken way to be going through the healing process. And in this healing process, you expect absorption too. So you have disrupted the absorption process. And therefore, it's not advisable to give them. A little advice to you guys, little advice. This is what I've realized. And I'm telling you, it's difficult to help. Because the moment you say A, B, C, D, it will move the whole world to here. And I don't know what is in you guys, these guys. I don't know. All that you are looking for is shortcut. Some will say that for Dr. Attakorah's class, he wants you to understand. And we don't want this. Hey, you want shortcuts. A lot of people who fail are those people who don't understand. It's the same as those who are getting as they are from senior high school, senior this to university. You see them with these A grades, but when they start, you see them that they are flopping because of the shortcut. I want you to sit, learn, understand. This is my principle. I want you to understand. Don't be looking for that shortcut. It will expose you. A question will come because you are looking for answers only. People are solving questions, and they solve it with you. You are happy. And you'll be moving around with these. There's one person here, there's somebody here, he gives you this. And this, a lot of things are going on. You are only, do you know what? Instead of sitting down to learn, if it's heart failure, sit down and understand your heart failure, such that in the way, anyhow the question is being put, you can write something. And people are saying that this area will come, and then you depend on these things. People are failing. Why? Because they'll be relying on these things. At times they'll say that they have gotten the question, and they will go and the questions won't come. And they will be relying on those things alone. I wouldn't have been going through these topics with you. It's important to sit and understand, such that when the question is asked, if it's MCQ, you understand. If it's this, my principle is this: understand and apply it, then to achieve. Look for questions, look for this, and you do it, and you are just relax. Just relax. The little that you have learned, try to recollect what you have learned. Just relax. I've done everything I'm supposed to do for you. The things that we have taught you, please learn them. It's a lot. And the MCQs, you don't know where the MCQs will be coming from. But for my part, I've done everything I'm supposed to do for you guys. It's like when you say A, you see within a second, it will travel like light. And people will say that I will not join the class. Why? Because I have the recording of. You can, let me tell you, you can get my recording. This, but every year I set new questions. So when I'm teaching, I know. So if you depend on the old recording, you'll be getting old questions. I know what I do. Sit down, and the things that you have been taught. If it's 15, make sure these 15 areas, I am not going to. I've seen coming out with topics from 8 to 25. These topics, my advice is that if it's 15 topics that you think you are learning, make sure these 15, any question that will come. So what I'm supposed to do for you, I have done it. It's up to you. Okay. So God bless you. I'll be seeing you on Monday. All the best.
Dr. Attakorah, we didn't see your face.
Doc.
No, no, yes, left.
Doc. Oh, Doc, you left the laptop.
Yes, ask your questions.
Why? Now you can be.
Bye, guys.
We are.
Matthew, this is what you are telling me.
Goodbye, guys.
All the best, guys.
All the best.
See you on Monday.
See you on Monday, guys. We'll be fine, okay?
Come again.
It's been nice being your class prefect. Bye.